Thank you, Jörg. Thank you for your talk. I learned a lot of new things. So toric lenses could be a good turn bank indicator. So, so my talk concerns aeromedical risk assessment following ENT surgery, and vice versa. We have to care for our patients when they decide to do an operation. And we have to do before operation, before ENT surgery, we have to do a risk assessment as well. We are the experts, we are the specialists, and we have to be close to our patients when we both have to decide to do an operation in this specialty. So the next clicker question. What is more likely, sudden capacitation caused by ENT events or gastrointestinal events? Oh, wait and see. The structure of my talk, a short introduction according to actual literature, the environmental and individual risk factors which has to be taken into account, the special and the routine and special ENT surgery according to risk assessment. And I want to show you two examples in decision making in the special cases in the ENT. And last but not least, the summary. In general, aeromedical decision making has to be done that no diseases or symptoms should be caused by the flying service or worsened by flying service, and incapacitation rate and unfitness rate must be excluded with a high rate of likeliness. We talked about the 1% rule yesterday. A short view to the literature shows incapacitation and unfitness due to ENT problems are very rare, as you can see here, and it's not changing when you see the work of James and Green from the UK. You can see that there's no big change between 1967 and 1988. Similar, the same rate of sudden incapacitation due to earache or ear block. And when you see this here, gastrointestinal illness, the rate is much higher. And in ENT, you only have a rate of 6% or 2%. Incapacitation, barotrauma, and barotrauma sinuses, barotrauma caused to illness of the ear. The typical risk factors which have to be regarded are noise, vibration, barometric pressure changes, spatial disorientation, psychologic factors, and climatic influencing factors influence the mucosa, which is an important area of the ENT region, and individual factors, the age, the flying experience, the type of aircraft, the question if there's a single or multi-crew operation, and last but not the least, it has to be counted the remaining time in flying service. Let's lead to ENT surgery. Own data. As of end of last year, we had counted 2,700 pilots, active pilots who had an ENT operation after their first flight physical, and that is about 11%. The majority is done in the oropharynx area and the nose and paranasal sinuses. So let's go to tonsillectomy. We had 173 operations in the oropharyngeal area. The most are tonsillectomies and sometimes combined with adenotomy. And the indications for tonsillectomy are mostly chronic infections, followed by upper airway obstruction, secondary to tonsillar hypertrophy, connected with sleep apnea syndrome, and 5 to 15% suspected neoplasm. The main risk, as you can see here, it starts sometimes very slight and increases in a heavy manner. Is the hemorrhagic rate. There's a big Austrian tonsil study that was published last year, and there were more than nearly 10 million patients were regarded in 32 ENT departments in Austria. And I don't want to go into details, but I only want to present you the results. And 60% have bleeding after the operation. It's a famous clinic where it is performed because it's a clinic in Graz, led by Professor Stamberger, and he followed Professor Messerklinger, and Professor Messerklinger was the inventor of the functional endoscopic sinus surgery. And the results of this big study, the highest hemorrhagic rate in tonsillectomy is 16%, compared to other operations, tonsillotomia, for instance. There's a positive correlation between age and frequency. The peaks of bleeding are the first day and between the 5th and the 7th days. The severity is dependent from age, and 4.9% had a bleeding level C or D. That means a bleeding which could has to be managed by general anesthesia. C, normal operation, and D with transfusion necessary. In this study, no fatal level was determined. The nasal cavity, we had 275 operations in the nasal cavity and 104 septum operations, sometimes combined with other operations, turbinates or sinus surgery. The complications of the septum surgery are different. The severe complication is septum hamartoma. As you can see here, it should be solved as early as possible because it could cause damage of the cartilago of the septum because of lack nutrition, and so you have to stitch in there and remove the hamartoma, and then it will normally running well. If not, septum perforation could occur, and we sometimes use a very simple solution. We use a septum button, which could be left in the nose for years and has no complaints. Other possibilities are to build flaps, but the outcome is sometimes difficult, and this solution is very easy and could be performed in surface anesthesia. Synergia mostly are seldom and mostly do not are the majority of our complications, but they normally have no functional disorders in the nose. The nasal cavity, the nasal turbinates also have can cause operations in the nasal turbinates can also cause complications. Major complications is the atrophic rhinitis when you remove too much from the nose nasal cavity. The humidification of the nose is running worse, and that could lead to permanent crusting, and it's very difficult to handle when you remove too much out of the nasal cavity. Short topic to the neck surgery. We have 12 operations in the majority in thyroid operations. I think we have 2 recurrence palsies in there, and you have to think for the risk of this type of operation: bleeding wrist, functional disorders, nerve disorders, motoric or sensoric, moving disorders caused by scars, which could also give problems using the equipment of the aircraft. And the dignity is an important topic as well, sure. When you see the rehabilitation time, when the pilots can go back into the cockpit, we have certain times. Septum and tonsillectomy we give free after 4 weeks, normally, if there are no complication occurs. Turbinates, nasal turbinates a little bit earlier, and after 4 weeks, after 2 weeks, and neck and soft tissue operations depends on the single case. Now leads us to special ENT surgery, middle ear operations. We had only few middle ear operations, mostly paracentesis caused to normal inflammation of the middle ear. And you have to account the risks, the vestibular disorders, hearing disability caused by problems with the ossicle chain, or going down of the inner ear by infection or operative side effects, nerve disorders, especially the facial nerve or the tympanic cord. The functional endoscopic sinus surgery are the second important type of operation. Is the second important operation we do in our clients. In every first examination, we do a routine MRI, and we see if something is running wrong with the paranasal sinuses. And we don't suggest them to go to the operator and to the operation theater and to resolve these problems by operations. We are not allowed to do this. We can promise them that they can fly after the operation. So we tell them, go to your ENT doctor, try to use a useful therapy that could be in the conservative therapy at the beginning. And after that, come back and we check it by endoscopy and perhaps imaging, MRI or CT. And when everything is running well, you have a second chance. They are temporarily unfit when they have problems in the first examination. The majority of the operations are performed in the maxillary sinus. As you can see here, it's a typical finding we find mostly in our first applicants. Even if they have no complaints, that could cause, at the pedestrian they will never have problems, but that could cause a severe sinus paratrauma because of blocking of the osteomeatal complex. So he has to undergo the therapy when he wants to fly. It's a slight symptom here. It's only the problem with the ethmoid cells, as you can see here. But that also could cause problems So it would be fine to start a conservative therapy, and perhaps in this case an infundibulotomia is necessary to remove the mucosa swelling in the nose. The complications in a big study were counted with 60,000 patients. The major complications were only 1%, and severe complications like bleeding, which requires transfusion, only 0.76%, or renal liquorrhea in 0.17%, and Jörg, only few ophthalmic complications. And special cases, I want to introduce you only in one example. That could be what? Severe or the slowly progressive hearing loss over years. And you have to be aware it could be acoustic neuroma. And take care, it's an important thing when you find a unilateral hearing loss, you have to take this in account. The rehabilitation time following special ENT tumors depends on a single case. Stapes operation, I will give you examples later on. It could be done in local anesthesia, but rehabilitation time is about 3 months. All middle ear operations, we have a rehabilitation time of 3 months. And functional endoscopic sinus surgery, we grant them the way back to the cockpit after 6 weeks normally. Now I want to give you 2 examples. The first example, first case report. It's a 40-year-old military pilot with a flying experience of 1,200 hours. And he has a slowly progressive hearing loss, and then he needs hearing aids in fighter pilots. Remember my talk last year. And he needs a waiver because he didn't pass the limits, but speech audiometry was slightly sufficient in cockpit noise surrounding. So he was a little afraid. That's a close connection to the patient. He was a little afraid to do the operation. He was afraid that he will lose his flying fitness. So we come together and said, okay, so long you understand speech and cockpit noise, everything is okay. But one time he came to me and said, no, even if I don't fly, I hate these hearing aids, I want to have a normal hearing without hearing aids. He knows that there was a possible solution by operation, but after a certain time he was convinced that the operation would be better, and we talked about the risks, and he said, okay, let's do this. He had an otosclerosis, and we performed a stapedotomy, and these are the results. This is the situation before. You can see here a typical air conduction hearing loss with Carhart's notch. That is typical for otosclerosis, and this is the situation after the operation. A very good outcome. And after 3 months, he could return for checking in the cockpit, but later on about that. The Aeromedical risks after this operation. The operation is performed by removing parts of the stapes, drilling a hole in the stapes foot plate by CO2 laser or by normal mechanical drilling. And then, therefore, a piston is put into the stapes foot plate. If the piston is too long, that could cause vestibular disorders. If it's too short, that could cause hearing loss or dislocation of the piston with hearing loss and possible perilymphatic fistula. So it should be done by experts. And our decision making is like that. As you can see on this example, wait and check first with normal audio monitoring. And then we check the bone condition, and with the bone conduction, when the bone conduction remains stable, it's okay. And when air conduction is also stable within certain limits, below 25 dB, and the most important frequencies 1, 3, and 4 kilohertz, we can keep the non-surgical concept. But when the bone conduction is becoming worse, and then we have to decide normally to do the operation, because you can solve the inner ear problems. And air conduction, when air conduction passes the limits of 25 dB in the main frequencies, also operation of stapedotomy is performed. And we do a special test after the operation to check the stability of the prosthesis. We perform a tympanometry causing high and low pressures in the ear canal, which leads to a movement of the tympanic membrane with a pressure of plus 600 decapascal and minus 600 decapascal. And simultaneously we record electronystagmography or video oculography, and when no nystagmus occurs, you can the prosthesis must be stable, and that is the first condition to go back to the cockpit. In general, conditions for wavering after stapedotomy, new surgical techniques, stapedotomy, as I mentioned, continuous audio monitoring with constant hearing ability, no vestibular symptoms, normal otoscopy, for instance, no scars in the tympanic membrane, because when you have atrophic stars in the tympanic membrane, it causes an abnormal movement of the tympanic membrane, and this is could be a reason for dislocation of the stapes. Normal ENT tympanometry, as I showed before, and then the permit to flight could be granted 3 or 6 months after therapy. First with OML, the jet pilot has some experienced flight in high performance situations with a flight teacher, and then he went back into the cockpit. After 1 year, flying without restriction is possible, and annual checks are mandatory. Now the second case, a civil pilot, airline pilot, with a squamous cell carcinoma of the nose. That is a situation with epithetic supply, and this is without. And the personal data, 40-year-old airline pilot with flying experience of 5,000 hours. He went to his ENT doctor because of earwax, and he was very thoughtful, and so he found out that there was an alteration in the right nasal cavity, and he removed it and detected a squamous cell carcinoma. The therapy was done in November 2010 with a lateral rhinotomia, functional neck dissection, and the staging was a PT1 tumor without metastasis. After follow-up 1 year later, there was a recidive in the right nose dome and nose tip, and that's difficult to handle. And so the operation was performed with partial aplasia of the nose and elective neck dissection, also with no metastasis. Now the tumor grading is it's now a PT2 tumor. After another clinical examination 1 year later, a squamous cell filia, high differentiated, was detected, and PET examination after resection had no pathologic finding. Because of this, chemoradiotherapy was performed, and the last examination was done end of the last year. and with no pathologic findings. The next step would be a pedicle flap, as you can see here. And then he will be checked in close gaps. The aeromedical concerns in this case, we have to go into the literature. A high-grade differentiation is better than a low-grade. That's obvious. And then there's a Öhngren area, and tumors below the Öhngren area, and in this case it was so, have a better prognosis than above. The 10-year survival rate over all stages is 37, but in his case, 5-year survival rate is 87, and the risk of distant metastasis is very rare, only 2%. So we can let him fly, and there is at first no risk for sudden incapacitation. What we want to have an MRI from the brain to exclude. There was an MRI, a PET MRI was done 1 year before, what just before let him to fly again. We want to have a new MRI of the brain, and we performed it, I think, last week, and it was okay. And another question is, how can he perform the Valsalva's trial with this epithetic flap? And we checked it, and he was able to do this in simple Valsalva, and the forced Valsalva, he has to fix his epithetic supply, and it works very well. So we had no restrictions, no TML, but we had a restriction, shorter intervals for examination every 6 months with a TML in his license. Risk assessment following ENT surgery is as important as ENT surgery following risk assessment. Risk assessment is a dynamic process of identification, analyzing, evaluating of risk, which has to be communicated, monitored, and reviewed. Sudden incapacitation caused by ENT problems are very rare. About 11% of our clients had ENT operations. Most operations were done in the nose and oropharyngeal area. With endoscopic sinus surgery, the most operations were done with the maxillary sinus. Periodic endoscopy is helpful after paranasal sinus operation. Ear and neck operations are rare in the flying community, and special examinations, as we invented the ENT tympanometry, could be helpful in risk assessment. Thank you for your attention.
Your question back is so you can show how well you've educated people.
Okay, convinced.
Thank you very much.
Thank you.
Excellent.